Eras Lucknow Medical College and Hospital in here in Lucknow, India. So the topic which was assigned to me was what is actually the introduction to OSCE and OSPE, and is there any difference with the current ongoing practical examinations as a means of assessing our students? So I'll start with my learning objectives. So at the end of this presentation, the health professionals connected would be able to know the basic differences between OSCE and OSPE. Just a minute, some technical issues. Actually, the PowerPoint is not visible here. Give me a minute, please. Yes. And you are familiarized with the process of conducting OSCE and OSPE, and we are able to demonstrate. I'm able to explain to you how can we develop stations and checklists for the conduction of OSCE and OSPE, and how we can ensure that the quality maintenance is there during this method of assessment. So let us start, and by knowing what does actually OSCE and OSPE mean. So this is an abbreviation where O stands for objective, S stands for structure, C stands for clinical, and if we replace C with P, then it becomes OSPE, and P stands for practical, and E obviously is examination, the method of assessment. So objective, we call it objective because examiners here are not giving marks as per their own will in a subjective way. They are using a pre-formed validated checklist for evaluating the trainees and the students. And it is a structured way of assessment because the students and the trainees, they undergo the same problem and they perform the same tasks in a given limited time frame. So it is same for all the students, similar exercise for all the students. And it can be clinical based problem or it can be a practical problem. So they are actually, these tasks which are given here are actually representative of those situations which will be faced by the students in their future life when they start practicing their professional careers. And examination, because obviously it's a means of assessment. That is what OSCE or OSPE stands for, full form of OSCE and OSPE. I think it's stuck. Next slide. Okay. So the OSCE or objective structured clinical examination is an approach to the assessment of clinical competence in which the components of the competence are broken down and then they are assessed in a structured way, and attention is paid so that the objectivity of the examination is not lost. As this was realized by many of the professionals, but Thomas Huxley rightly pointed out that students work to pass, not to know. Actually, when they get admission in a professional course, most of the students, they're just there to pass their exams. And only a minority of them are there who really are passionate and they want to know the nitty-gritties of the course they have been admitted to. And the students, they do pass and still they don't know. So that was the flaw which was realized by many people, and that is how this OSCE and OSPE also came into being. So OSCE is a clinical or practical examination, but which somehow, or there are a lot of differences between the practical examination which we are used to taking, like Viva and OSCE and spotting and other examination. In the practical type of exams, it's a bit different. In a non-clinical area, a similar approach may be adopted, and that is referred to as OSPE, or Objective Structural Practical Examination. So OSCE is for the clinical branches and OSPE is for the non-clinical or allied branches. It is assessment of the performance and it is concerned with what the students can do rather than what they know. So basically, it tests the domain of the students where their skills are being tested. So if we see the basic differences between OSPE and OSCE, although both are similar, but still the domain being tested is psychomotor and affective domain also in some cases in OSCE, whereas in OSPE it is the knowledge part which is mainly tested. We are not able to test the affective domain. Usually the time taken for one station or for one student to complete the task in OSPE is around 5 minutes, and maximum can be up to 15 minutes if we make many substations there. And in OSCE it is more than 5 minutes per station. These points will be re-emphasized when I will mention how it is conducted, OSCE and OSPE is conducted. But basically OSPE requires one big hall where the students can rotate. When the bell rings, then they can go to the next station, and similarly they can keep on rotating in a clockwise or anti-clockwise fashion. Whereas in OSCE we usually require small isolated places. They can be isolated with the use of a curtain also, not necessarily they should be small rooms, separate rooms. And the examiners, the number of examiners is lesser in case of OSPE, whereas in OSCE we require expert examiner for each station. Checklist is required for both. Standardized patients are not required in OSPE because it is basically non-clinical side, and for clinical side, patients might be required. Observers are obviously required for OSCE, and in some cases of OSPE, they might be required, but usually it can be done without the need for observers. So why was the need for OSCE and OSPE was felt? Because we were already taking the examination, practical examination, and the students were also satisfied. The teachers were also okay with that. This was also again realized by many observers, like Mr. Harden, Dr. Harden. He is a pioneer in this field. To obviate the drawbacks of conventional clinical evaluation, objective structured clinical examination was introduced first by Dr. Harden in 1975 as a more objective, valid, and reliable tool of assessment. Because now we are moving towards problem-based learning, and this curriculum requires students to be able to integrate the basic and the clinical sciences. So in an ideal OSCE, all the domains of the competencies, whether it is the cognitive domain, psychomotor domain, or the abstract part, all of these competencies are tested. And the examination is organized in such a manner to examine all the students on a similar ground, on identical content by the same examiners, but using a predetermined guideline. And a systematic feedback is obtained both from the students as well as the teachers. So OSCE is meant to test shows how level of Miller's pyramid. Let us just revise Miller's pyramid because its name has come up. So let us just revise it. So I hope all of you are familiar with this Miller's pyramid, which is for assessing the clinical competence. At the top of this, the small area occupied is the most important, which is does, how the student performs. Below that is the student knows how this is happening or how to perform exactly. He knows the steps. That is shows how. Below that is knows how. That is he knows the theory, but he doesn't exactly know that how it is performed. Then comes at the bottom is the knows. That is the knowledge part. So the student might have just learned it by heart. That is rote learning, by fact gathering, but they don't know exactly what is happening, what is the pathophysiology, how it is being done, or exactly how to do it, how to do this particular task. So the lower two parts, that is knows and knows how, they usually test the cognitive domain of the students, whereas shows how and does, they show the behavioral part or the skill part or the affective domain of the students. So we want to test this part. If we want to test this part, shows how and does, in a setting where we actually don't put the patient, put the students in a real life scenario, but still it is a simulated environment, controlled type of environment, and still the student is doing what we desire him to do in a correct manner. That is how OSCE came into being. OSCE or OSPE came into being. For the newly joined participant, let me elaborate. OSCE and OSPE are the two ways of assessing our students, mainly for the skill part and the affective part, affective domain. And this is the OSCE means objective structured clinical examination, and OSPE means objective structured physical examination. So clinical examination is where we have clinical branches where we deal with patients, real patients, and OSPE is for testing those specialties or those professional fields where the clinical part is not there, but still we have to do practicals. So some examples of OSCE is like we can ask the students that you have to take history from one patient. A patient can be a fake patient. He must be tutored already. That what answers you have to give. So history taking from a patient who presents with pain abdomen, for example. Or we can put a fake patient that this patient is an asthmatic patient and you have to explain him how to use an inhaler, proper use of inhaler for asthma. So the examiner will just be standing there. They will not interfere with the students' this functioning. They will just see and note down whether they are performing all the steps correctly. And another example can be communication with the family, with the other members of the healthcare team. Like when we are taking rounds in the wards or seeing the patients. So there's so many members, like there are technicians, there are nurses, and there are some other attendants, ward boys. So how one person communicates with the others in front of the patients, and the instructions are clear or not. So that communication skills can also be tested with the use of OSCE. Or we can test examination of like the student to examine the cardiovascular system. So we will just write down that perform cardiovascular system examination of this patient under the headings of inspection, then palpation, then auscultation. So they will just write down. Another example of OSCE is like diagnostic procedure, which can be like using an ophthalmoscope. What are the steps you will perform while using an ophthalmoscope in any patient? So they can be taking a consent, taking precautions yourself, how we will position the patient. So all of them will be entered in the checklist, and the examiner will be just standing there and seeing whether the student is performing this procedure correctly or not. It can be written communication, like there'll be a placard saying that you have to write a patient's referral letter to a higher center, or you have to write a discharge ticket. So what points are you going to focus on? There should be patient particulars, name, age, address, phone number correctly, his diagnosis, the consultant who was uh, treating the patient, the residents who were treating the patients, what diet he has to take, what kind of exercise is advised, what medications have been advised. So all this can be tested by using the OSPE. Wherever patient is there, we say it is OSCE. When patient is not there, we say OSPE. P is replaced, C is replaced by P when there is no patient. Then we can place some charts or ECGs or some reports, lab reports for the students to for their level, which they can assess, and they can make a differential diagnosis, or some question related to it can be asked, like these are the patient's reports, what dietary advice we like to give, or these are the reports, which food should be avoided in such a patient. So they can have a clinical correlation. Or we can just give them that, you have to write treatment for the radical cure of malaria. But this writing a prescription, actually we are not testing they know the drug's name or not. We are seeing whether they have a legible writing or not, which is easy to read. They're putting the patient's name, age, gender correctly, and they're signing it or not, date is there or not properly. So all the things are being taken into account, apart from obviously the content which they are writing. Now, a range of techniques can be employed in the OSCE to emphasize the practical nature of the examination, so that it does not turn into a theory examination of a short duration. So sometimes we can place patients who are not actually patients, but they're simulated patients. They're just acting like patients. Or we can give them short videos of patients. If actual patients are not available, we might have some videos like patient walking like a drunkard. So we might have a video of that patient. Actually, that patient might be having some cerebellar disease, and we put that on some monitor, and the student plays it, and some questions are then asked about it. What type of walking disorder this patient has. So there can be different ways of asking the questions. They can be simulated patient, there can be videos, they can be charts, lab values. which we can place as a station in the OSCE. So everybody says that OSCE is a objective exam. There's less of subjectivity. So what factors contribute to the objectivity of this examination? Now, candidates see a number of examiners in the course of examination. Every station has got at least one observer or examiner. So everybody is testing all the students. All the students are going through the same path. It's not that like one person is taking viva of 20 students, other person is taking viva of 20 students. One examiner is giving very good marks, another one is giving very less marks. So the students will also be disheartened to see that they don't want to go to the examiner who is known to be very strict. But here what is happening, that all the examiners are standing and they are judging and giving marks according to the performance of the students. And what is to be assessed at each station is agreed in advance, and marking schedule is provided, and which lists that what is expected of the candidate at each station. It is already clear that if the student forgets this, you have to give this mark. If the student comes back again and does this step later on, then you can give half marks. So it is already decided. It's not that this examiner has to decide then and there. Then examiners uses a checklist. What is a checklist? It is, I will show you an example of checklist. It's just a numbering. This numbering is done, serial number of steps is done, and the steps are mentioned clearly for any procedure which we are testing. They can be 5 steps, they can be 10 steps, they can be 15 steps, depending upon how elaborate the procedure is. So examiners use checklist which reflects what is being tested at each station, and this is agreed in advance by the examiners. Now, the aim of actually taking the OSCE is to produce a profile for each candidate rather than composite mark. For example, some students might be good in theory, some students might be good in communication skills, some might be good in psychomotor skills, psychomotor domain. So as a whole, we are testing our student from all the domains, and that creates a profile of our student. And what will be the criteria for passing or failing? That should be agreed in advance. That how many marks are we going to say that this person has passed or failed, or they have attained distinction. If we see, even in the OSCE, there is some fine marking procedure. That is, they can be checklist marking or they can be domain based. Checklist means it involves that mark sheet is broken down into individual components of the task being performed by the candidates, and the examiner ticks the stage which the candidate completes. Like, for example, I will just show you a checklist, and then we will come back to domain. Let me show you what does the checklist look like. First, let's see what are how do the OSCE stations look like. So this is actually an open hall in which this OSCE is being performed. Although ideally there should be some curtain between where the patients are lying down so that they have privacy for examination. At least where there are these 3 stations where the patients are lying, they should have curtains or closed ones. But for the sake of showing you that how OSCE station looks like, this is the picture. So we can see that 6, 7, 8, 9, 10, maybe this is 5. So all these are numbered stations. These are numbered stations, and at each station there is some question. Here, like, it is in the form of some audio, some visuals, and about which the questions are asked, and the students has to write the answer. Here we have one patient, and maybe their students has to perform some examination, and this is the observer who is sitting here, examiner, and he's seeing what are the steps being done by the student. Here again, this is a writing type of, like, there's a question on the table and then they have to answer it. Suppose this is writing prescription for any disease. Now the 8th one is again a patient based, and here examiner is sitting here checking or ticking all the boxes whether the student is performing correctly or not. Again, student is performing some test on this patient and the examiner is standing here. So similarly, you can have as many stations as you want to desire, the areas you want to test, and you have to have these observers and examiners wherever you have a patient, or you have to see whether their students are performing correctly or not. So I was telling you about checklist. Let me first show you checklist, and then we will have come back to domain based. And so checklists they're designed and incorporated into OSCE to increase the objectivity and reliability of marking by different examiners. So this is like a checklist for nasogastric tube, which we teach the students, our students. From the second year, we start teaching them skills. So like you can see that there is a subheading in this checklist. This is actually a domain. So introduction and orientation. So if I put marks here, like if I put 10 marks for introduction and orientation, so it will become domain-based checklist, domain-based OSCE. But if I give individual marks to all these steps, then it becomes checklist-based OSCE. For greeting the patient, 1 mark. For reading the prescription of the patient, why this procedure is being done, again half mark. Informing the patient that this tube is being inserted in your nose that will reach the stomach and reassuring him or her, 1 mark. Confirming the name and identity of the patient, 1 mark. Ask the history of nasal trauma, nasal block, nasal surgery in the past, 1 mark. Tell the patient to sit on the couch, 1 mark. So we can give marks, like we can give marks to the total of this, that is this pura subheading, full subheading, that is introduction and orientation, as total 5 marks, 6 marks, or we can individually break them down and see whether each step is being performed correctly. Then positioning of the patient, then examining the nasal cavity, asepsis is being followed or not, accuracy of the skill with which nasogastric tube is being inserted, offering the patient to swallow slowly, thanking the patient for cooperation, checking the nasogastric tube. Like I was explaining this to my students in a mannequin nasogastric tube insertion. So we can mark in 2 ways the OSCE. One is the domain based and another is checklist based. So a checklist approach involves a mark sheet being broken down into the individual components of the task being performed by the candidate. An examiner just sees the patient, observes the student, not talks to the student, and just ticks that whether he's doing it correctly step by step. Each and every step is marked. So the domain based, also called rating scale or global rating, in this method, individual checklist items are replaced by the broad categories. Like patient safety is being taken into account, physical examination was done properly or not, 5 marks for good physical examination, 3 marks for poor examination, 1 mark for not doing it correctly, or everything is wrong, 0. So we can break down, we can give marks to the subheadings, or we can give marks to individual steps. That depends on the examiners, how they want to rate your OSCE. So OSCE, as I have shown the diagram, the figure, that the basic structure is a circuit of assessment stations where the examiners, using a previously determined criteria, assess range of practical skills, clinical skills on an objective marking scheme. Marking scheme is checklist. So it may be necessary to read out the clear instructions to the candidates. Before starting the OSCE, the student should know that in which direction they have to rotate, how much time will be given to them in each station, or alternatively a clearly written instructions should be there in the board, on a board in the same room. So before asking our students or testing our students, it is good practice to perform the dummy run of various stations. Suppose you are performing OSCE for the first time in your institution. So before introducing the students or testing the students on this, it is good practice to perform dummy run of various stations, which enables the examiners to like they can see whether they are able to complete the work in 4 minutes, 5 minutes as being asked by the students. If they are able to perform easily, then maybe we can give it to the students. The same time should be given to the students. Also, we have to see that because like we are giving 5 minutes for each task or 6 minutes. So whether the task which is the lengthiest one, is the student able to complete that in 6 minutes, or he needs more time? So we can place a rest spot after that where they can complete some parts if they are left. So we have to see before designing that this thing is kept in mind, that we cannot give 2 minutes for each station. Even the lengthy things, like there are 15 steps in one procedure, we cannot give just 2 minutes for that station. And candidates should be given answer sheets to write down, obviously, the answers in unmanned stations where there are no observers. So how do we set up an OSCE examination? First of all, we have to know which skills we are going to test or assess. So ideally, by blueprinting, we can perform this initially, like making a schedule or timetable. We usually write down the name, the date, the day, and the task to be performed. Similarly, before commencing or starting the OSCE, we should write down which skills are we want to assess, how these skills can be broken down into different parts, and we prepare a grid by breaking them into different subtasks. Now, subtask, how much marks and how much time will we give for these particular subtasks, and how many marks we are going to assign to them. So, duration of each station we have to decide, like 5 minutes each. How many stations we are going to keep, like 20 stations are we going to keep, or 10 stations. Obviously, we have to see how many examiners we require, and we have. That way, we have to design our OSCE stations. Then logistics of the examination. Obviously, where we are going to conduct the examination. We need a big hall, or we need different cubicles which are adjacent, so that no time is wasted from moving from one place to another. What materials we use, we require for a table, a chair, or for visual presentation, we need a laptop or computer. So if we want to add new stations or remove the older ones, they should be decided beforehand. And who will be the timekeeper in this OSCE, who will be ringing the bell. A checklist for each station should be validated and prepared beforehand. Then patients, they should be ready. If we are using these patients, standardized patients, they should be ready with their histories, and they should know what is going to be done with them next day. And this overall planning of the examination should be done beforehand. And at that time, signal for station change, who is going to give the signal for station change, and we should keep these records for future use. So this is just a small document which shows that how OSPE is being performed. This slip will be for exam organizer. This will be for candidate for station 1. This will be for examiner of the station 1. Suppose this task is for examination of the olfactory nerve, that is the first cranial nerve. So this will be placed at the station, and in the station, on the station, it will be said that you need all these things: pen, table, chair, everything is required for the organizer. This is for the organizer, and this is to be placed at the station, that OSCE station, that you have to examine the olfactory nerve. Then the candidate will be asked that name the test in which the given material is used. Like if suppose some things are kept to smell, so we can ask which cranial nerve is used, will be tested using these materials, and what type of receptors are present in olfactory epithelium. This is just an example where we don't have patients, but we are just taking examination for practical examination for physiology. Then examiner will be having a, if the examiner is there, they will be seeing that how many marks they have to give. For example, the first answer is olfactory nerve. So obviously testing the olfactory nerve will be the right answer. They'll give 1 mark to this. And the chemoreceptors, if they write correctly, then they will give 1 mark. This is just an example of very simple station for a physiology practical. So the tasks to be assessed should be of different types and varying difficulties to provide a mixed assessment circuit. It's not that at every station you can have a patient, or at every station you can have, every small station you can have a written type of things, or audio or visual, like visuals, so that patients, the students will be subjected to same type of questions. So it should be a mixed bag type of things. The task in OSCE depends on the level of students training. If we are training the first year student, obviously the questions will be easier. And as the difficulty level of that course increases, the OSCE difficulty of the questions asked in the OSCE will vary. There's no hard or fast rules to the skills being tested, but they're determined with the aim of assessment. So we should obviously have what are the objectives with which we are going to assess our students, what we want them to know. So that should be asked in our practical examination, which is OSCE. We are already halfway through our presentation. Checklist I have already discussed, but I will just revise this. The checklist are the numerical lists which are used by the examiners, who is not disturbing the student at any station, but they're just holding the checklist in their hand and seeing that whether the student performs each task or subtask, and they just give the marks that this subtask has been performed. Okay, I will tick this. Okay, the student has performed this correctly. I will tick this. So they are just lists which is a listing of the subtasks of one particular task which we are going to assess by this objective, structured, clinical, or physical examination known as OSCE or OSPE. So checklists are designed into and incorporated into OSCE to increase the objectivity and reliability of marking by different examiners. So already I have read this, that nasogastric tube, like we insert in a patient, we have to introduce ourselves. We have to see we are talking to the correct patient by seeing his records. Then we position the patient, examine him, and then by aseptic conditions, we insert the tube after measuring the distance with which we have to proceed inside. So, just a minute. So these are all serial numbers of the checklist, and these are all steps of the checklist which we can prepare for our own task which we want to test. So this checklist is for insertion of nasogastric tube. So similarly, the examiner will see that student is doing all of these correctly. They're inserting the tube gently down the throat till the required length. They're securing the nasogastric tube. They're checking whether it's in the correct position by doing aspirating the gastric contents and taking out a chest X-ray to see whether it is placed properly or not. So all of these is being just done by the student, and it is being ticked by the examiner. They're not talking to the student here like a typical viva in the practical examination. Ultimately, they are thanking the patient for their cooperation, and this tests their this affective domain. So to communication skills, affective domain, psychomotor skills, and some part of the knowledge. All of these are being tested by this OSCE and OSPE. So this was the I was explaining my students how to perform nasogastric intubation for an OSCE. Again, we can play for a physiology practical, like we can have different stations, and these stations, for example, can be check and record blood pressure. One person will be sitting there, and blood pressure will be recorded. Then another one is you have to list 5 factors, write down 5 factors which help in maintaining the blood pressure. In third one, we can ask them to take temperature, record the temperature. The fourth one can be a rest station where they can complete the leftover work. The fifth one can be they have to convert some degree centigrade into degree Fahrenheit. Then another station can be you have to test urine, this given sample, from the given sample test for urine and albumin. Then after they have tested, then the next station can be list 5 causes of albumin in the urine. So they can be related also. Two stations can be related. Like you have been through the previous station. What do you think which drug will benefit this patient? So they can be related. 2 stations can be interrelated also. So this is an objective structured practical examination of this anatomy, where they had 12 stations, and each station had 2 marks and 4 spots for identification. So they have like for upper limb practical, they had 4 spots which they have to identify. So for the identification spot, the neat pins are placed, or the some marking is there which the students have to write down. That number 1 stop is this, number 2 stop shows this, number 4 shows this, and number 5 shows this. So without actually asking the students that tell me about upper limb anatomy, gross anatomy, tell me about this muscle, that particular muscle, the questions are just the upper limb specimen is there, and they are marked by needles. Like number 1 is name this muscle. Number 2 can be written in the paper there in the placard over the table that mention the function of this muscle, or insertion origin of this muscle, insertion and origin of this muscle, nerve supply or arterial supply, So these type of questions can be asked without actually asking them, and every student rotates through the same part, same thing, so that they are subjected to similar, they have similar exposure, same questions are being asked. It's not that one person is asked very difficult question, the other one is asked very easy question, which they have not read, which they have read. So there'll be no bias actually. That is how objectivity is maintained in case of OSCE and OSPE. So apart from OSCE and OSPE, some other terms have also been devised. Like one is group OSCE, especially useful in not in a final assessment but in formative assessment. Formative assessment, I'm sure you must be knowing that when we take assessment, but not for the purpose of passing an exam, but for giving feedback to the students that how they're performing up till now, how much they have learned. So that is formative assessment, because that is rectifiable, remediable. We can tell them, okay, you have scored very poorly, now you have to improve, you have to work on these areas. So for group OSCEs, where we have less number of examiners, we have less resources, there we can have group OSCEs where a number of students, 4 or 5 students, they go to one station and then they perform the task and then they move on to the next station. Team OSCE is a bit different from the group OSCE. Team OSCE, we assign different functions to each and every member of the team. So suppose one person will become the physician, one will become the surgeon, one will become dietitian, one will become the psychologist, one will become physiotherapist. So they are assigned the jobs and then they are given a scenario. Suppose they are given a diabetic foot patient, and then they are asked, how as a team are you going to work to improvise or to manage this patient? So that is team OSCE. Then remote OSCE and computer aided OSCE, like we are having this presentation by the means virtual presentation. So that is how the remote OSCE can also be performed, like examiner is sitting somewhere else and they're just seeing by the use of camera and audiovisual aids are used, computer aided. So real examiner is not there, but they're observing the students, how they're performing, and or the virtual scenarios can be given to the students, like they are not actually seeing the live patient, but they are seeing in the computer and they are being shown all the clinical signs present in the patient, and then they are asked the questions that this is the patient, how we will approach, or what is the rash which is being shown in this patient. So there can be virtual scenarios provided to the student in different stations, or this can be that examiner is not sitting there with the student, but with the help of a camera they are seeing that whether all the steps are being performed correctly with the use of a checklist. So these are some of the other terms which are used. Sometimes the students are confused, like whether they will be able to pursue this course or not. So what we can do is, there's one term called admission OSCE. Actually, this should be done first as a part of career counseling, I think, because some of the students who opt for some profession and later after admission they come to realize that they are not meant for this profession. So at the time of admission or before giving the admission examination, they should be undergoing this admission OSCE, so that they know that they're suitable for this particular course or not. So this is another term which has been coined. So now we have dealt with till now what is OSCE and OSPE, what was the need for OSCE and OSPE over and above the practical examination of Viva OSCE, which we usually take. And now we are coming to advantages of OSCE, and obviously when there are some advantages, there are going to be disadvantages also. So the advantages of OSCE, apart from its versatility, like we can have a number of stations, numerous things we can test, an ever-broadening scope, are its objectivity, reproducibility, and easy recall. The students get examined on a predetermined criteria on the same or similar clinical scenarios, and the marks are written down against these criteria, thus enabling recall. So it's not that there's no bias actually in marking. If they have done it correctly, the marks are given. If they're not done it, then marks are not given. So it is just very objective. And OSCE can be used for teaching also and for self-assessment. Like it's not that only for the examination day this will be open. So OSCE can be practiced beforehand also, so that if they're going for some exam or some like they're appearing for some practical exam, they can practice on the OSCE stations also. And it's not a rigid method of assessment. There's lots of flexibility which can be incorporated into objective structured clinical examination. Now, what do we mean that if we say that flexibility can be incorporated? This means that it can be used in, first of all, it can be used in preclinical branches, paraclinical, psychiatry, or other allied branch subjects. Any subjects which are concerned with health professionals, they can be applied. So that is the flexibility. It is not limited to only clinical branches. Then we can use them for all type of students, whether they are undergraduates or postgraduates. But obviously, according to our objectives, the stations will be changed, and their level of this difficulty will vary. Then at any stage of examination, they can be used. They can be used as pre-test, in the formative assessment, in the final assessment. They can be used. So they can be used at any stage wherever we want to test our students. Then according to the resources available, we can plan our OSCEs. It's not that we need to have 5 stations where patients should be there. No, it's not necessary. If we have one mannequin, one patient, it's all right. We can have other unmanned stations. So whatever resources are available, how many number of examiners are there, how many patients we can arrange, accommodation for patients, obviously we have to arrange. So some examinations are held in clinical settings, while others are held in like non-clinical settings, depending upon our students and which course we are assessing. So there's a lot of flexibility. There's no rigidity in case of OSCE and OSPE. And performance, we know, is not judged by 1 or 2 examiners, but team of many examiners. So this is advantageous to both the examinees and the institute, standard of the institute also, because outcome is not affected by any prejudice. Then OSCE takes much shorter time, although it appears that there are a lot of stations, but still the students keep on rotating every 2 minutes or 5 minutes. So it usually takes lesser time to assess a broad subject, a broad that variation you can test in a shorter period of time. Now, as there are a lot of advantages, but there are certain drawbacks also from the objective structured clinical examination and practical examination. One is that OSCE has been criticized for using unreal subjects, even though actual patients can be used according to the need. So sometimes the unreal subjects, they don't show the same signs. Like if we want the student to know how a jaundice patient looks like. So obviously our unreal patient will not have that jaundice, which we want our students to see. Or the expressions, the facial expressions of the patient, the real patients are different. Unreal patients, they just learn some things like which they have to tell the student, but they're not real patients. So that creates a bias. Like when they actually see the real patient, they're somewhat different, looking different. So this has been said for OSCEs. Also, if any place is not having a lot of resources in terms of manpower, or they don't have enough time or financial support, labor. So, and it also requires a lot of careful organization and planning. So suppose in a department only 2 or 3 people are there and they have to take care of everything. So taking an OSCE becomes a laborious task and difficult one. So we need to have manpower. For OSCE, we need to have some resources, actually, not a lot if there's not much resources, but still we need some resources. Then we have to train the examiners and the patients for this task, because planning is important for OSCE. If we just start today, like for Viva, we don't need any planning. The examiner just come in the morning, sit there, and they just start by calling the roll numbers of the students, and they start giving the marks. From the maximum marks they see, okay, I have to give marks from 100, I will give 50, or I will give 40 if I want to fail. So that is a simple thing. But for OSCE, we have to do some preparation beforehand of the examiners, as well as the fake patient if we are going to keep in the exam. Then we have to train those patients also. We have to prepare stations, checklists. So it's a time-consuming affair. Although if we do it once, then it will be yielding later on. But still, once we have to do it. And traditional OSCE does not integrate competencies, rather assesses in fragments. So it is usually a robotic thing, broken down into different ways. We are not actually testing in, we are testing each step. Like it is also like a rote learning. If the students come to know that there are these steps, they will be just learning the steps, and they don't actually perform it, that they are like they are performing a skill. It just again becomes a sort of rote learning. If they come to know of the checklist, they will learn the checklist and they will be performing out accordingly. So we have to perform a certain task so that we can maintain the quality of the OSCE, or the objectivity of the OSCE is determined by the skill of experts who prepare the checklist and the stations. So the stations should be prepared with the all panel of the examiners should sit together and plan the stations, and then individually they should prepare the checklist and others should validate them. Higher objectivity does not mean that it is a highly reliable thing also. So they are related although, but it does not mean that objectivity is there, so it will be reliable also. And obviously OSCE has good acceptability among students because they are subjected to similar tasks, so they think they are being treated fairly. So how we ensure the validity? We ensure that validity by blueprinting. Blueprinting ensures that if we have an OSCE which takes into account all the psychomotor, the knowledge part, the skill part, and the abstract part of the testing, then obviously it will be a valid one. And we have to prepare a schedule or the blueprinting before we come to the stations part. So first is blueprinting, then comes the station, developing the stations, and then we develop the checklist. Now, some things can make the OSCE less reliable. This includes if we are having fewer stations, like we have only three stations or 5 stations, and students are rotating in them only. If we are not having, we are having very simple tasks. We don't have proper checklists. We have time constraints. We are rotating the patient very haphazardly, very quickly. So it will defeat the tasks. If we don't have proper patients, that the examiners and the patients are not trained properly, and or if we plan a very lengthy OSCE, then also the student fatigue will be there. So for hours, if the OSCE is going on, then obviously everyone will be fatigued. So most important is planning, blueprinting. Then comes the preparation of the stations, training of the examiners, observers, and the patients. Then comes the preparation of the checklist. If sometimes the checklist becomes that they're leaked, like we cannot prepare checklist every year. So if the seniors give the checklist to the juniors and they can somehow learn it, rote learning, so they will not be performing the tasks by themselves. They'll be just carrying out the steps in their mind, and they have just learned the checklist. So leakage of checklists can also be, they can seriously compromise the validity as well as reliability. So some of the things are there which are drawbacks of OSCE. So the students should be given the opportunity to practice the OSCE techniques. And how they can do it? Obviously, they can talk to the real patients. They can, with their consent, they can form small study groups to perform at different OSCE stations. Initially, they can perform in groups, and later on, they can perform in isolation. Like we have a skill lab in our college, and then the students are posted there, and they are practicing with their peers also, and alone also, so that when in the exams they are asked to perform the skills, they don't feel uncomfortable, and they know all the correct procedure how to perform. So that's all I think about the OSCE and OSPE, which is a not a very new but relatively new way of assessing our students in the health sector. So I think it's my presentation is almost over. If anybody has any question, I'll be willing to answer it. So I'll conclude, then I'll wait for 1 or 2 minutes for any questions. So OSCE, or objective structured clinical examination, should not be seen as a replacement for something. For example, a case presentation or a viva, table viva is separate thing. It should supplement other tools of assessment. and it is better to design stations to test competencies in an integrated ways. So we should not be over enthusiastic to use OSCE examination for competencies which can be tested by other means. Like if you want to have a long question about anything, then you don't want to concise it, and but you want to test it by OSCE. So every literature or every part of the curriculum deserves a different set of assessment tools. Some are good by asking in the theory part. Some are good by when they're assessed in the practical. In the practical too, some are good when we ask them by Viva. Some are good when they are asked in OSCE. So we have to determine what type of questions or what curriculum or of we can test assess by these OSCE. So the need of the hour is integrated or the three-dimensional assessment in its true perspective, of which OSCE can be a component. OSCE cannot replace all the practical examination, the Viva, the case presentation, but it can be a supplement to the these practical examination methods, where all others are not able to compensate, like for testing the our affective domain and the communication skills. So thank you so much. This was my talk on this.
Madam, one question.
Yes, please. Please introduce yourself.
Yeah, I'm Ismail. I am from the Department of History.
Yes, please.
Yeah, regarding this checklist that you mentioned, I just wanted some clarity. How do you do it at your place? Because it is, one is giving the marks, and but do you have an overall grading on whether the student is pass or borderline or fail or
Yes,
good?
yes,
So that's an important aspect of a
yes,
checklist to overall globally grade.
yes,
And what happens is that when an OSCE basically uh, is done in various streams, 200 students, and perhaps you might be having three streams or sometimes even two streams. So it's important to standard set amongst the examiners as to who is a pass student or who is a good student, especially for the ones whom you are planning to fail. For example, when you're talking about the nasogastric insertion, you might
yes,
have achieved the step, okay, you breathe and you read the prescription. But suppose if he is not inserting it properly, he doesn't check it. So those are again important aspects, though we say it is objective, but at the end of the day, examiners, when they are in that room or examining, some sort of subjectivity again comes into picture.
you're very
Another thing with OSCE is the prompting of the students, guiding them. That happens a lot. And as you rightly mentioned, the training of the examiners is very important. But we all are different. So some of us may are inclined to be very strict. So those are again some of these drawbacks I just wanted to.
yes, yes. You're very correct, because we cannot have 100% objectivity. Otherwise we can we will have robotic examiners, but that too again will have other drawbacks. So everything has got their own pros and cons. But the first thing which, sir, you asked about the checklist is that obviously we have to prepare checklist with the whole panel should sit there, who are all stakeholders, that we have to prepare checklist for this particular skill or these particular skills, and the skills have to be given marks according to the importance of the steps. Like if they're not inserting properly or they're not checking properly, so that should have more marks as compared to if they
No,
don't
no, but
read.
but but then do you have global rating at your place?
Yes,
No,
overall rating of the skill is given, like for example 50, out of 15 marks, how much they have scored.
no, no,
So
no, not marks. I'm not talking about
rating
marks. I'm asking about whether
grades.
it is a pass, fail, satisfactory, good.
Yes, 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 sir. Meets expectation, we have like that: meets expectation, below expectation, and this achieves the goal. That type of grading system we have. Marks
So,
can
so,
be,
now- so
actually, that is a separate topic that we have to convert, if we have to convert the marks into grades or grades into marks. But skills, for skills we have this, whether they have done it correctly, then satisfactory, meets expectation, below expectation, and then fair, like three grades we have there. But then again, we have to somehow convert these marks into these sub steps. For sub steps, we have to check, put a check that they have done this, they have done this. Okay, correct, they have done this. And then we have to count how much percentage of corrects are there, checks are there. Then only we can convert it to whether they have done it correctly or they need more again practice, or they are doing very
Because,
poorly.
because overall in these stations, how do you calculate the pass marks? You know, whether it is borderline regression or whether you're doing a borderline method, because
Because
you
we
know
uh
it
yes.
might not be that you are setting it at 50% and you say all above 50%. So, what is your criteria for passing a candidate at that particular station? Because what can happen is a student might score 70% of marks, but if
Yes,
that whole cohort is doing good, then that student can actually fall below the if
average.
you're doing a regression, if you might fall below the line and then actually fail the exam. I have seen students failing even 15 out of 20 because the
Mhm.
pass mark for that station actually after the cohort performed was 16. So how do you decide on that particular pass
Actually, sir,
criteria?
uh, in MBBS, what we have is that in different phases, we have different competencies, which we have to test by skills. And those skills are also classified that these are like very important. They should be must know. Then they might know, and then they're lesser importance. So those who have been placed, which have been placed as they must know, that they have to pass. And then by the completion of the final year, they should pass all these must know competencies. That is our aim. And then this is a part of not summative assessment but a formative assessment. And when the final exam comes, then they are graded according to whatever like marks are given to OSCE. It's like OSCE does not form a chunk, मतलब majority of the chunk of practical examination. It might form 20%, 25%. So that obviously has an impact on the final marks of the student, but not that much impact. That is how we are doing it. Although we have also started final year from this year for final year MBBS as a part of CVME curriculum. So this year we had this exam where we placed these OSCE stations. We are also learning in a stage of learning.
Okay. Okay. Can I ask, Dr. Saab? My name is Dr. Kaisar Sajjad.
Yes, sir. I'm listening, sir.
Okay. I missed your presentation, particularly the disadvantage of the OSCE. Can you please repeat the disadvantages of the?
Sure, sir.
Because I have a question on that.
So these are just that sometimes unreal subjects are used. So this is being said that actual patient should be used, but many of the times they are not either available, or so simulated patients are being used. That has been criticized. Then it requires resources like manpower, labor, time, money. So it requires careful organization and meticulous planning. Like we cannot just come one day and get started. So we have to do some planning beforehand. Training of the examiners and patients prior to the OSCE is important. That is required actually, and that it is a like again a robotic type of things that they are doing it in parts. They're not doing it as a flow in a flow. That is some people criticize that they are integrate does not integrate competencies. They assess in fragments. So these are some of the drawbacks. Apart from that, sometimes the students the checklist is leaked, and then they learn the checklist and they just rote learn it. That is also said to be a drawback of OSCE.
Okay, my question is that we give a limited time for the OSCE examination, because, for example, 20 or 25 students in a hall is attending one station, second, two, three, four, and the at the given time they have to answer that questions
Yes.
with the actual patient or the simulation or like instruments or whatever it is.
Yes.
So what recommended time can you mention to what recommended time it should be so that the student can be assessed properly?
So this was also mentioned in one of my slides. I don't know whether I showed
Can
it
I,
to
can
you.
I answer that
Maybe.
question, madam?
Yes, yes, please, sir. Please
So,
go ahead.
you know, actually, Dr. Kesar, you know, there are variations to
Yes.
that. Generally, if you look at how it is, it might vary from something like 5 minutes, and it can go up to even 11 to 12 minutes. If you look at the OSCE stations that are done in the MRCS exams, they are basically 11-minute stations. Our university also, we are somewhere around that same time. So there's no fixed time, you know. There was a time in our
No, Ismail, my point is that in MBBS, what we observe that the students are giving only 3 minutes, 3.5 minutes, or बहुत हुआ तो, I mean 4 minutes. So I think it's very difficult to assess the students in 3 minutes or 3.5 minutes or
exactly,
4 minutes. It's very difficult.
exactly. You know, we had earlier time, we had two types of OSCEs. One was 6 minutes and the other one was 14 minutes. But we have now come up with a standard one, which is around 11 minutes. So that was earlier
So
classified as a short OSCE and long OSCE, but now we have only
So
one.
you, your point of view that which I agree that it should be from 5 or 6 minutes to 11 or 14 minutes,
Yes,
which
right.
is I think which is I
Even the
can say it
MRCS,
should be
even the MRCS OSCEs are around 11 minutes.
11 minutes. Yes, yes,
But
you're
out
right.
of this
Long
11,
OSCE and
but
short
out of
OSCE is a good idea. Like a small task which are can be given in small OSCE, that is 4-5 minutes, and long OSCE 11 to 12 minutes. That is a fair distribution. And one more thing I would like to say,
What, so,
yes,
madam, can you say, well, short OSCE means? Can you give then any example how short OSCE?
suppose we give some lab reports, like a patient who is anemic, and we give a short like description lab report. This is hemoglobin, these are the MCV, MCHC, and all these values. What type of anemia? Then few questions regarding that. What type of anemia do they
Right.
need?
Okay. I got it.
Questions.
That's
And
fine.
long,
That's
like
fine.
third
Okay.
side in like MRCP, they have those, so communication, like breaking bad news, and after seeing
Dr.
the reports.
Dr. Kessel, like for in your setup, if you're an ENT surgeon, it will be like perform Weber's and Rennie's test. That's all.
Yes, so 5 minutes is okay.
Yes. Yes. That is more. That is. I think it's more time given to just perform the Rennie states. You are
Yeah,
absolutely right. But if
but there you can ask them, you know, like what is the appropriate tuning fork, and then you can have one or two
yes,
questions between bone conduction and air conduction. So that will be ideal for.
exactly. I mean, if the Rennie test is positive, what it means, what it could
Yes,
be.
Exactly,
interpretation,
exactly.
interpretation. Yes,
Exactly. So then it means that if we have 4 5 questions on that domain,
interpretation.
so then we have to give at least 5 to 6 minutes, I think.
Yes,
Yeah,
because
you
we
know,
don't, we should not, we should run a
you
dummy this OSCE before we give to the patient students, actual students, so that we should see how much time we are taking being examiner, how much time our like we can put our SRs or the JRs there if we are going to test the MBBS students. So how much time JRs are taking? If they are taking 4 minutes, that means MBBS will take obviously 5 to 6 minutes in correctly answering the question. If they don't know, they will do it in shorter time.
Is there any other question? If not, we call it a day. Thank you, madam, for such a wonderful
thank you so much.
session.
Thank you, sir. Thank you, participants. Thank you, sir.
All the best. Take care. Goodbye.
Thank you, sir. Allah Hafiz.
Allah Hafiz.